Next presenter is Dr. Kavya Chandran.
Very good evening to everyone, and my name is Dr. Kavya, and I'll be presenting the long-term outcomes of descemet membrane endothelial keratoplasty combined with retropupillary iris claw IOL implantation, and this is a case series. On reviewing our indications of endothelial keratoplasty at our center, we realized that pseudophakic corneal edema and aphakic corneal edema comprise about 50% and 6% of all the cases that we perform. And this has also led to a change in the trend of performing endothelial keratoplasty over penetrating keratoplasty, which can be seen over the last decade or so. A repeat review of the indications also concurred with the previous values of PBK and ABK, forming a sizable chunk of the indications for which we perform endothelial keratoplasty. Now, when a surgeon is faced with this scenario, he has to make a choice whether one would perform a DSEC or a Dmek, and also the choice of the secondary IOL between anterior chamber scleral fixated and an iris fixated IOL. In view of these complex eyes, one should keep in mind that the challenges of poor visibility due to scarring, presence of pus, eyes which have undergone prior vitrectomy, presence of vitreous in the AC, an unstable IOL, and previous glaucoma filtration surgeries can pose significant challenges. And we have seen that DSEC appears to be the surgery of choice in these eyes. However, with our study, we aim to prove that Dmek can also be safely performed in combination with an iris claw lens. An unstable IOL may require IOL redialing and IOL exchange based on the capsular and bag support, and the different IOLs should be kept in our armamentarium, which include anterior chamber, scleral fixated, and iris claw lenses. Anterior chamber IOL are the easiest to learn, but they provide lesser space for manipulation of the EK graft. Scleral fixated lenses have a risk of posterior dislocation of the graft. In contrast, an iris claw lens is easier to perform, has a stable and deep AC to maintain your air bubble, and a lesser risk of graft dislocation. These can be both anterior and retropupillary, and they derive their name from their appearance to a lobster claw lens. These are the different IOLs that are available for us, and the instrumentation just includes an extra hammerhead forceps and an enclavation spatula or rod. Coming to our study, we aim to assess the long-term outcomes and survival of Dmek grafts done in combination with retropupillary iris claw IOL implantation. This was a retrospective review of 4 cases of bullous keratopathy performed between February 2021 and 2022, and data on the pre, intra, and post-operative clinical details were collected and analyzed. We had 50% male and female patients, and 3 patients were operated for pseudophakic bullous keratopathy and 1 patient for aphakic bullous keratopathy. The mean age at presentation was 70 years. 3 of these patients had mispositioned PCIOL, whereas 1 patient was aphakic, with a mean preoperative BCVA of 1.78 logmar. The mean preoperative central corneal thickness was 665 microns, and the duration since cataract surgery was around 20 years. None of the patients had clinically visible pus at presentation, which enabled us to perform a safe Dmek, and the mean anterior chamber depth was about 3.28. Good quality donor tissues were used with a mean count of 2,600 cells, and the average age of the donors was 62 years. Post-operatively, we noted that corneal clarity was maintained in all cases till the time of last follow-up. However, 3 patients had glaucomatous damage with raised IOP post-op, and the mean best corrected visual acuity was around 0.8 logmar. All patients who developed glaucoma post-operatively interestingly had shallower ACD pre-op in the absence of clinically detectable pus. These are the distribution of the age, intraocular pressure, and the donor cell count, and the box plot showing the improvement of the post-operative best corrected visual acuity in our patients. So these are some of the images of our cases. This is the first patient with aphakic bullous keratopathy with a visual acuity of 2400 at follow-up. The next 3 patients are pseudophakic bullous keratopathy in whom we perform Dmek with an IOL exchange and implantation of an iris claw lens. This is a third case who had an improvement of 20/40, and the 4th patient whose vision improved to 20/100. So this is a collage that shows how the clarity has improved in all the patients, and they have achieved good visual acuity post-operatively. So to conclude, I would like to say that Dmek in complex PBK and ABK presents unique challenges. Careful decision making is warranted, and retropupillary iris claw lens is an effective and predictable option to combine in these complex eyes. The limitations of our study were a limited sample size and lack of consistent follow-up, for which we could not obtain specular microscopy counts post-operatively, which we aim to do in the future. And we would like to expand the indications of Dmek in complex eyes with this study. Thank you.
Nice presentation. So Kavya, Did you attempt or have you attempted or is there any other study at your center with ACIOL? Dmek with ACIOL?
There are studies published at other centers which have compared ACIOL and SFIOL for both DSEC, primarily
SF would
for
behave
DSEC.
essentially like this.
Yes, yes.
But
Nothing that we have looked at for ACIOL.
The number is a pretty small number actually, so
Yeah,
I'm just wondering why only 4 it's not like something very
I
rare.
wanted to we wanted to look at a follow-up for a longer period to see how they behave. So I included cases only which have a 1 to 2 year follow-up. But we have had cases following that. So I did not include the recent cases because we wanted to look at the long
So visual outcomes in these 4 cases also a little underwhelming from what I'm seeing.
Because 3 patients had glaucoma
and
because of the long chronic presentation. But in terms of success of the graft, we did achieve it. So careful selection, we noted a point of shallower ACD pre-op. So we can use that as a surrogate measure to maybe warn these patients of suboptimal recovery due to the underlying glaucoma.
So difference from any SFIOL would probably be that maybe the anterior chamber would be a little more deeper. I don't know.
Yes, so SFIOL also
would also
the
be
risk
deeper.
of potential
Space between the two.
iris and the SFIOL, and in a Dmek you have a risk of posterior dislocation of the graft. So because the iris claw lens is in flush with the posterior surface,
so the
of the
chance
iris,
is lesser.
So your AC is maintained, and it also overcomes the problem with the ACIOL where you have contact with the graft. So in comparison with these 3 types of secondary IOLs, what we realized was the iris claw may be a safer option in these complexes.
With ACIOL, it's probably not you said the distance is less, the AC depth is less, but that's probably not the issue. It's just that the lens is closer and
also the contact.
When you're trying to get into
if you're doing a DSEC surgery, you can still go ahead, but a Dmek, because you require so much of manipulation to open the graft, so it might.
I know you guys have been doing a lot of DSECs with the iris claw lens. So do you have any patients in whom you're getting these recurrent inflammations? I've had a couple in which they keep coming back with uveitis.
So far we haven't had like case selection in terms of health of the iris, absence of previous uveitis, past. So all our patients did not have that. So we found that those patients are better candidates for iris claw lenses.
Sure.
In general, in a secondary IOL, not in a Dmek or DSEC case, how is that a primary secondary IOL for you now, or is it?
At our institute, we have both options of ACIOL, SFIOL, and iris claw.
Earlier it used to be ACIOL, of course.
Surgeon.
But scleral is not too.
Scleral also we do.
So you mentioned there was 1 ABK and 3 PBKs.
Yeah.
So why did you have to remove the PCIOLs?
Unstable.
They were unstable?
Yeah, they were unstable lenses with vitreous in the anterior chamber. So we could not do the Dmek without explanting the PCIOL.
No, understood. Thanks. Okay, so thank you very much, Kavya.